for joining today. My name is Caleb Corwin, and I am a psychologist with the Center of Excellence for Children in State Custody. For those of you who don't know, the Centers of Excellence for Children in State Custody are across the state, located at 5 different sites. I can advance my slide. Located at 5 different sites across the state. And we primarily do consultation for complex cases for children involved in the child welfare system. And so that's kind of how many of you all may know us, especially our DCS friends. That's how we've come to know many of you all. In addition to that, though, we have the opportunity with our best practices group to do some training for clinicians and others on best practices in behavioral health services, evidence-based trauma-informed care, and other topics. And part of that is we've created a monthly lunch and learn series, and this kind of came out of that in a certain way, right? We do this monthly lunch and learn webinar series the second Friday of the month for an hour and a half, and we do various topics relevant to children involved with child welfare and at risk of child welfare involvement. And that's been really good, and it has grown, and many of you may have joined some of those talks. And so this space kind of grew out of that, as well as from other discussions that have happened. Dr. Mosier and Dr. Hoffman having some conversations and recognizing the need for this for so many of our children who are in the child welfare system, who also have intellectual disabilities, developmental disabilities, and just the frustration we've had with knowing what services are available, just kind of our own educational needs of wanting to know what's out there, what things we can get them connected to, and wanting to make sure that information is shared, because we know our colleagues at Department of Children's Services are doing everything they can to try to help these kids and these families as well, and kind of trying to make it easier for them to be aware of what services are out there. And so this is kind of our journey, part of our journey to increase that awareness and that access. And so we're excited to have so many great speakers here with us today, from many different agencies, mostly from Department of Disability and Aging, but also from some of our MCOs, BlueCare and WellPoint, United Healthcare, who are going to talk about many of the different programming options and services they have available to these children and these families, which I was putting together these slides and I was like reading through, and I was like, oh, I can't wait to hear them talk and explain these things, because there was a lot of information that was really new to me on there. And so I'm really excited for this talk today. And I'm going to turn it over to, I don't know if you guys have finished like paper, rock, scissors for who's going to talk, but Trey, I think you look the fanciest, so I think you might be up for talking. Okay. And I will advance your slides. You just let me know when to go.
Sounds good. So just to kind of start off to everybody, I want to thank everyone for taking the time out of their day to attend and to be a part of this. I do want to thank all 5 of the COEs for hosting this and putting this together. This is something that about a year and a half ago, I guess, I had approached Dr. Mosier and had kind of opening a conversation about DDA's work and kind of moving into providing its expertise or lending its expertise in areas with the Department of Children's Services, especially focused on kids with high medical acuity, complex medical cases, as well as creating a program to offer some financial assistance and support to foster families that are supporting kids in custody that have that intellectual developmental disability or enrolled in TEIS. So in meeting with Dr. Mosier, this is, we kind of realized that there are a number of different things that are going on, other partners that are out there, and we've all kind of been siloed a little bit in our approach and how we were trying to do things. And I think from that conversation, it really kind of expanded that it would be great if we could get everyone at the table to really kind of focus on everyone's efforts and what they're doing and how we're all working together to really achieve the same goal. So that's part of this. So I do want to thank Dr. Settle, Dr. Emerson, and Ms. Mentor for coming on from our MCOs to really talk about how their roles and what their organizations are doing to really enhance and support kids that are in their networks, and some of the behavioral health benefits and other things that may not be known to foster families in general. Those things are kind of available. So that's kind of the kickoff to that. And then from our DDA side, Bo Hickman, as well as Bria, from our maps and Katie Beckett. I think these are some other areas as kids that are focused on that at-risk population or before they come into custody. Are there things and services that we could look at providing that may be able to stabilize those at-home placements that we can prevent some of these things? So we have some other areas we're trying to cover the full gamut and laying out that. So that's part of this presentation and what you'll hear. So I hope that kind of gave a good understanding. This was on the fly. So if I sound out of breath, it's because I ran from one building to the next to get to this presentation. So please forgive me for that.
Well, thank you so much for inviting me to speak. I did kind of shortly before we jumped on, looked through the slides. As you guys mentioned, all three of the MCOs are going to be speaking. So I see Dr. Settle on the camera and BlueCare as well. So I just want to preface my slides by saying some of the things that I'm going to talk about are pretty, there are standardized across all three MCOs. I mean, we do share the same benefits. I chose to just kind of touch on a few of those here today, and then there will be some things that I talk about that are unique to United Healthcare. So I do expect that most of you are familiar with some of these behavioral health benefits. I didn't really want to go through the details of them more than talk about how they specifically can relate to our children and adolescents with intellectual and developmental disabilities as they present with, like you mentioned, a more complex profile. So just really wanted to focus on, ABA and touch on, CAST and CCFT and really just the commonalities between those. So again, these are all, behavioral health benefits that are can be accessed through each of the MCOs. But I think the commonality is that they're focused on keeping children, in that natural environment and preventing out of home placement. And what I really wanted to speak on is just the ability to assess that child or adolescent to determine, which one of these benefits are going to be most appropriate for that child and adolescent to maintain those goals, to meet those goals of maintaining the natural environment and staying at home with family. So they all include what I think is the most important, that parent family component. And so when we're thinking about ABA, that is the intervention that for our children with intellectual disabilities, specifically, autism, that has a lot of research behind it being successful at managing those problematic behaviors and training parents to be able to implement those strategies. Now, Anna, Dr. Settle, I looked at your slide, so I know you're going to really cover Group 7 and Group 8, so I'm not going to steal your thunder, but I did want to touch on it. And you guys later on in the presentation are going to get a lot more information on ECF choices and how those particular home and community-based services are in place to support children and adolescents as well. But I did want to touch on Group 7 as that is our, within the ECF choices structure, which, as you guys know, is our waiver for individuals with disabilities to be supported in their home and community. We do have two groups that target children, and those are Group 4 and Group 7. So I didn't focus on Group 4, but I think there might be some education in this presentation. Group 4 is still supports to assist families with caring for their child or adolescent in the home environment. But Group 7, we developed several years ago to really support those children that have complex, challenging behavior to the point that if they don't receive an intensive intervention and the parents and family do not receive a high level of support, they are at risk for being, not able to be supported any longer in that setting. But I wanted to mention those three other benefits prior to that, because some of the things that, when we're looking at, is Group 7 appropriate for a child? It is our highest level in ECF. We do look at have there been other interventions within that behavioral health continuum that have been attempted and have been unsuccessful? And like I mentioned all of those benefits are important because they really assume that there is a lot of participation from the family and the natural supports, because we want to transition those skills over to them. But that's also important for group 7. We want the family to be committed to participate in that intervention, because that's when that level of intervention can fade out, and the family is then able to implement those same strategies, and maintain that stability. But again, we're looking to see at the MCO level, what have we tried within the behavioral health continuum that's been attempted but maybe unsuccessful, and the child really needs this higher level of supports. And I know Dr. Settle's going to do a great deep dive into it, because I saw her, I peeked at her slides. Okay, last, next slide, please. And this is something that is unique. I think I think we have something similar across all 3 MCOs, but just want to touch on that. I know that we do run into situations where our children and adolescents do experience a crisis event, and it is important for them to potentially access out-of-home placement, short-term, maybe acute stabilization. So I wanted to just kind of educate that each of the MCOs, this is our particular support process, can provide that support, in real time. We've had a little bit of we haven't had a lot of this activity where we're getting outreach from mobile crisis or an ED to assist with placement, but we do have a process for that. And I did include the triage number here. What happens is that if you are supporting a child or an adolescent who is experiencing a crisis event, and it does look like they really do need out-of-home treatment or acute stabilization, but because of their complexity, and as you guys know, we do see a lot of that complexity with our children with autism and intellectual disabilities, placement, finding that setting that that is receptive to treating them and is equipped to treat them can be a barrier. So we have developed a mechanism for outreach to be made directly to the MCO, to our triage line, and they will provide in real time assistance. And sometimes that may take several days of trying to figure out what that facility looks like, to find an accepting facility. But we do have that partnership, and want to start having more outreach made, so that we can assist, and we're not having children and adolescents go unserved when they do need that level of stabilization. I've included here our triage number to help in those crisis support situations. And I think I was well within my 10 minutes. So thank you guys so much. I'll be on though if there's any additional questions.
Thank you so much.
I'm now going to unmute myself. Mute myself successfully, I hope, here.
All right. And I think I'll turn it over to Dr. Anna Settle.
All right. Well, you can tell that Dr. Emerson and I work together frequently, because we just sort of naturally took different parts of the presentation. So I'm going to dig in a little bit more into the ECF services, and then I'm also going to include some information so that you can do a little bit of research and learn more about the behavioral health supports that we have available. As Dr. Emerson mentioned, those are pretty standard among the MCOs, but I wanted to include some links so that you would have access to learn as much as you would like about those services. I'm going to start with our ECF services. And I know that Dr. Emerson mentioned groups 4 and 7. So I think those would be the services that you're primarily interested in. However, we get a lot of questions about levels and group numbers and group changes and who qualifies for which group. So I think that this brochure is really helpful in delineating those things for you. I wish I was there in person with you all to give out this brochure and this information, but we'll do the best we can virtually. It's a lot of information in a small space, but there are some QR codes on there that are helpful if you want to scan those to get some more information about application process. Also includes what's available in each group. So we have services that are available within each group of ECF. And then in addition to that, of course, people will also have access to the behavioral health benefits. So within group 4, as Dr. Emerson mentioned, group 7 is a little bit more intensive. And so group 4, our essential family supports group, is really for families who are caring for people who are up to age 21 who have been diagnosed as having an intellectual and or developmental disability. So this really is about stabilizing at-home placements. This is for children who live at home with their family. And the focus of this group is, of course, family stability, maintaining the placement at home. And in addition to that, we want the children to be implementing certain techniques that they may be learning through their behavioral health benefits that are being taught to the caregivers at home. So that could be through CCFT or ABA. Sometimes prior to that, the child may need psych testing or neuropsych testing. And so within the links that I'm providing at the end of our slides, you can take a deeper look at what those look like and what the referral process is for those. I will say that what I've found for our children and adolescents who have a primary diagnosis of ID or DD, CCFT often doesn't cover what they need. It's not intensive enough for their needs. It's not specific enough to what they are needing and to the family unit. So I'll just say that as a caveat. Oftentimes we see group 7 being more successful in those scenarios. So really the purpose of group 4 is to provide the opportunity for community participation and integration. We also want to have financial support for the family to cover services that they need. And then also when appropriate, when a child reaches adolescence, we want to look at employment and more community integration that's age appropriate. And then of course, the family assistance can include other opportunities to have access to things like assistive technology or enabling technology. Really, we just want to make a plan that's person specific and supporting the individual's needs and also the familial unit's needs so that we can maintain tenure in the home setting. So I will move on to group 7. Group 7 is our, you may have heard it called a few different names, but the full name of the service is Intensive Behavioral Family-Centered Treatment, Stabilization, and Supports. And it is exactly that. Within group 7, of course, the primary requirement is that the child is diagnosed with an intellectual and or developmental disability. They can be up to age 21 living at home with family. And really this group of children and adolescents has a significant potential for risk of placement outside the home due to the behavioral and psychiatric symptoms that they are exhibiting. So a huge part of group 7 being successful is family participation. And so we do a lot of work around that at the beginning, explaining to the family what is involved, ensuring that the family is shored up and able to learn and to implement those strategies. Sometimes families need assistance and relief, and they aren't necessarily at a place where they're able to learn and to implement a treatment plan. And so there are other ways that we can prepare the family. But once they get to group 7, it really is about learning and implementing strategies and treatment. So this includes in the beginning of group 7, there's a family-centered assessment that identifies the needs, and then we incorporate that into a comprehensive treatment plan for the child or adolescent, also including the family unit. Most often there's a behavior support plan. This could be a behavior management plan. Sometimes we see it's staff guidelines initially until we really learn the child or adolescent and what those specific behavioral needs are. It includes individual and family therapy. We want them to have linkage directly to psychiatry. So we don't want children kind of languishing in the community without an identified psychiatric provider. So we want them to be able to get in quickly so that we can ensure that those symptoms are treated effectively. And then cross systems crisis planning and response 24/7. And then what's unique about this is that there's an independent support coordination team with actually the MCO. So that's why you see Dr. Emerson and I, and then also Dr. Amos with Blue. So we're psychologists that actually engage in those meetings and we're part of the treatment team. So the support coordination team will include the conservator or parent, and then also include the child is appropriate or the adolescent is appropriate, we also include that provider and the clinician. Most often it's a BCBA. And it really is intensive, and there's a lot of oversight. We meet in the beginning at least weekly just to ensure that we don't have siloed care and that all needs are being met. We pivot and we can incorporate things into the treatment plan as things unfold, as treatment unfolds, as psychiatric symptoms begin to decrease, or if they increase as we're making med changes. So it really is a comprehensive service all under one umbrella with the intention of stabilizing the child or the adolescent at home. Next slide. So within group 7, once the child or adolescent is stabilized, we do incorporate these other services. So community integration and support services. Of course, we want the kiddo to be out in the community, engaging, being part of meaningful life activities, and improving quality of life. Our goal is to have the child or adolescent be self-sufficient and independent. We want to ensure that they have access to local resources and other activities, making sure that we're educating the family who may not necessarily be aware of those. And then we also have assistive technology and adaptive equipment that is available to them. So any tools, supply that can assist with functional needs, those are available, and that includes an assessment process where we look at the specific need that's being requested and all of the current technology that's available to meet those needs. So that's been a pretty cool benefit that we've seen used often. Then any minor home modifications, so any accessibility improvements within the home that are needed, community support development, so just building the support networks in the community, family caregiver education. So we want to ensure that the caregivers are trained and that they're adequately implementing the treatment plan, but also aware of other services that may be available that the child or adolescent needs. Family to family support, so connecting families with shared experiences so that they can support one another. And then decision-making support, counseling to assist with any informed life choices that need to be made when you have children who are moving through the process and they're aging out of group 4 or group 7, ensuring that we're making that a streamlined process, and then have them understanding and the parents understanding what the services are beyond group 4 and 7. Then any health insurance assistance, so guidance and understanding the coverage, completing forms. We all know how cumbersome and difficult that can be sometimes. And then, of course, employment services as appropriate.
Dr. Settle, there's a question in the chat that says, what happens after the person turns 21? Yeah.
So on the very first slide, in our portion of the presentation on that brochure, it explains all of the different groups of ECF. So there are groups for those adolescents who are aging out, and those are explained in detail. If you go to scan the QR codes, you can get into the space where it talks about each level, what's included, which services aren't included in each group. So here I just included some points of contact for our behavioral health team and some resources here. So any clinical questions or clarifications, if you want to know more about the services that Dr. Emerson mentioned, you can just shoot a message to that first inbox. And then if you have a child or adolescent who is in the community and behavioral health needs are not being adequately met, you can go to that second mailbox and refer for behavioral health case management. And this is a really great service. We've seen this for children who are in rural areas who even may be aware of the services that are available but can't find them within their geographic region. Our behavioral health case managers are fantastic at linking to resources and really finding a way to make it work so that a child can get the service that he or she needs. So those are 2 mailboxes. And if you send a message to behavioral health case management, it doesn't have to be lengthy. It can just be the member's information, the need that you have, the concern that you have, and we'll just make sure that that gets connected to the correct person. And then some additional resources at the bottom. So that first link is our behavioral health portal, and it'll take you to the behavioral health page. And it really is more for providers, but I think it's a great resource because you're able to see the different modalities of treatment. Yes, thank you, Dr. Corwin. And it has, within that site, it has forms that are required. So if you have a child that is needing CCFT or needing ABA, there are some forms that have to be completed on the front end of that. And usually we can streamline that and facilitate that. But if there are any questions about what information might be needed in order to expedite that process, you can click on the forms and take a look at those. And this is our second, the second link that I included. This is our behavioral health provider newsletter news page. And it has hot off the press, current information, BH information specific to children and adolescents as well. It has a lot of brain links information included there. And then you can see right almost at the top is the ABA provider. Sorry, now it's at the bottom. Provider requirements and program description. And so we recently modified our program description and our ABA provider manual. And you can take a look here to see any changes if you're interested in ABA or want to learn more about the population or what's required in order to meet medical necessity for that service. And then the last link, I believe, is Psych Hub. And I just included this because it has a lot of great information and resources, also trainings. And for those of you who have a license, it also includes some free CEUs. So this is just a happy bonus for you all, but it does have some great information on most current modalities of treatment, research, and the way that we're incorporating those as an MCO. And that is it for WellPoint. Thank you all.
Thank you so much. Free CEUs. I mean, at least for me, that's exciting.
That's right.
All right. All right.
Hey, this is Melinda from BlueCare, and I'm a case management supervisor with BlueCare. And working with me is Erin Key, who's available to jump in and share some tidbits. And she is the utilization management manager for our behavior health team. So I appreciate Dr. Settle and Dr. Emerson speaking about Group 7 and a lot of our joint services for our IDD members and special populations. And we also had those same programs, but BlueCare, we're thorough in how much we put in our PowerPoint, but this is really for your reference and you can use in future need. But I'll jump in and talk a little bit about how BlueCare's approach to supporting members, particularly, and you can move forward on the slide. Thank you. So one-to-one support, but what that means is for our members, they may have one particular case manager or person that they're speaking with, but there is a whole interdisciplinary team behind them. So we always talk with members or foster families and or even providers and let them know you may have one contact, but know that there's a team behind, working behind to ensure that we can meet the members' needs as much as possible. So that just is showing our, what we call our wheel of all the different disciplines, from nurse case management to peer to support, LTSS programs, all of them here, pharmacy technicians available to support the members. We'll move forward. But speaking about our behavior health case management and our approach to working with families. I'm sorry, we have a lot of slides. So we do have dedicated case managers through our behavior health, and this is a team of case managers who are licensed in mental health services and or our nurse managers. And we are available for a number of consultations and working with families. We participate in the child and family treatment team meetings, professional meetings. We work with trying to find members' resources, helping them make referrals for outpatient services, maybe just explaining benefits. Sometimes we know for our families and our foster families, understanding and navigating between different providers, if there's different coverages, different enrollments, it's a lot. And it's where our case management really shines, or any case management, is to really kind of help put together and help a family navigate what's available, assess the member's needs to find out what type of services may be most appropriate for the member, considering their diagnosis, their age, different behavioral presentations. So we really kind of have that team to work with the families, the foster families, and even the providers to kind of guide through some of those next steps and what's available. All right. BlueCare also has what we lovingly call our special cases case manager. And our special cases are for our members that are just really, truly complex medical behavior. There may be some behaviors or diagnoses that make them very difficult to place or receive certain services. These could be members that have arrived at an emergency department due to a behavior escalation, and there's just not a lot of, or I should say, there's a lot of barriers to discharging this member into the next level of care. So we do have a case manager specifically available to work with ERs and mobile crisis, with providers, with families. And we do have the contact at the bottom of that email. You'll see the email for an inbox. And I do supervise that person, Christy Troutman, and she is available after hours and on weekends for calls if we have a member who may be in an ER. And sometimes we have mobile crisis outreach to us for that member or for Christy as well. So we do have that team that offers kind of that specialized, in the moment, urgent need services. All right, and just highlighting how we work with mobile crisis. And since this team seems pretty well versed on what mobile crisis is, what they offer, what they do, this is just kind of a slide to highlight some of that extra work. And again, our support in the, if a member shows up at the emergency department, mobile crisis is called in to assess. And if there's determination that they need a higher level of care, such as an inpatient placement, but maybe mobile crisis is struggling to find a placement that will accept the member because of the complexity, or maybe the foster family doesn't feel comfortable bringing the person back home unless some additional supports are in place in outpatient services. That's what our case management and specialty case management is available for, to support both mobile crisis, those ER providers, and those families. All right, some of the levels of care, most of you may be familiar with these. And again, these are available through each of the MCOs. With the specific provider types, behavior analysts, peer support, psychiatry. Again, these are all, most of you are familiar with these levels of care and the providers that offer these services. Next slide, thank you. Different treatment options, specifically for outpatient therapies. These could be master level counselors, it could be group therapy is built in with that as far, and individual support. Through counseling, and it could be through telehealth as well. So it could be in person, and we have the telehealth option. Outpatient medication management through psychiatrists, nurse practitioners, or PCPs. And that is something that our case managers can assist with. And with BlueCare, we do have pharmacy technicians. If there's a problem or an issue with a foster family or a provider, maintaining or picking up medications, we do have pharmacy techs that will help outreach with that process. I know any of us can get very frustrated when we deal with prior authorizations for medications and any of that. So we have pharm techs that can step in and help with that med management as well. And then psych testing, we get a lot of requests for psych testing. So we do try to help link members with providers in the community, especially if there's specific testing needed, like a psychosexual test or just a psychological based on trying to get a full scale IQ for intellectual developmental delay, autism. So all of those we work to find psych testing for our members. Next. So then we talk about the higher levels of care in terms of outpatient programs, which we'll speak about here, and then our partial hospitalization programs for youth as well. Next, please. Additionally, residential programs. So if we talk about residential treatment centers for youth, we have a list that we maintain of specific providers across Tennessee, but also if it has to be out of state, if they specialize in IDD services, again, psychosexual disorders, if there's a specific need. So we work with providers across the state, but also out of state, if there's a particular disorder, as well as substance use. I will mention that many of our residential programs do have both psychiatric and substance use treatment available within the same facility. So if a member needs more of a substance use care, we can focus on that. And then our crisis stabilization units, we do have a few that will accept youth, particularly about ages 16 and up. Usually CSU is not going to accept the younger population, but some will accept teenagers. And then acute inpatient psychiatric withdrawal management. So we do work with our providers, and we do have a team of case managers specific for residential treatment care, as well as a transition of care case management that supports families in preparing for a person to discharge from a residential treatment or an acute inpatient, as well as kind of help set some of the family expectations of what happens when a member is in a higher level of care and how to coordinate and be part of family sessions, treatment planning, and so on. All right.
And Melinda, there's a question in the chat that says,
Sure.
Where can I find the behavioral health collaboration manual that you're using?
We have just the case management on, I think, that first slide through BlueCare. Mainly is calling, you can call customer service. If you had the members, their insurance card, there's customer service, and they will see, you can specifically request a behavioral health case manager. Or you may contact that inbox listed on our, I think it's our second slide for our specialty case management. Yes, the BlueCare special cases. And we monitor those frequently and daily just to see if there's general questions about collaborative care or specific needs, then we do check those frequently. And there is a behavior health case management phone line there as well. But you will see that's Monday through Friday, so that's not on the weekends or after hours. But that's where we would use the phone number for Christy listed there, or myself. I do carry my phone around on weekends. I hate it, but I do.
Thank you.
All right. So our continuous treatment team and comprehensive child and family, this is the same with the other MCOs. These are your typical services. They're intensive in-home. So you do have a therapist coming into the family home and working with the family to develop treatment plans, work through some of the basic psychiatric or behavioral problems that may be occurring. And it's really kind of family focused. And then if it's an adolescent, it could be CTT. So it's more focused on that treatment team. So I know there's a lot in this slide. It is the same with the other MCOs. So I'll move. And that is for any child and adolescent with any diagnoses. We'll move forward. Just some other frequent behavior health services. Again, our link with mobile crisis with our triage team, and as well as Tennessee Health Link. So we do have a number of child and adolescent that are part of those Tennessee Health Link. And Tennessee Health Link, or THL, more frequently known as, is part of the community mental health centers. So most of you are familiar with those. Those are our large community health providers. There's so many I can't even name them, and I don't want to highlight any one over the other because they are statewide programs. But Tennessee Health Link is a really good program that we connect most of our members to. So I just want to point in some of the benefit here is transportation to highlight on, again, some of our foster families for different reasons. Our families may not feel comfortable transporting the member or have access to reliable vehicles of their own. So we do offer transportation to medical appointments. So if a member is in a partial hospitalization or intensive outpatient program, or just going to their routine health appointment, then we can offer transportation and coordinate that with a member through a Verida. And I did want to point out frequently requested non-covered benefits, because I'm sure across the board in the MCOs, we get requests often for these type of programs, like a true daycare or an adult day program, or even now that we're in the summer day camp. And those routinely are not covered benefits. Personal assistance for someone to come in the home and kind of act like the personal assistant, that is not a behavior health covered benefit. Now, you can see similar services within ECF choices and sometimes specialty things under home health. But as far as a behavior health covered benefit, personal assistance is not a covered benefit. And we do get frequent calls from members, families, to ask if there's some type of in-home, like babysitting, if you will, or just in-home care. And we truly don't have that through a covered benefit. Also, animal assisted therapy, equine therapy, those are not covered benefits through Medicaid behavior health. Okay. All right, our specialized IDD programs. Well, ECF choices. So again, thank you to Dr. Settle and Dr. Emerson for presenting these. It is the same with BlueCare, our ECF programs. But our behavior health case managers work hand in hand with our ECF choices team. So it very much is an integrated care team. So if we have a member who is in ECF group 4 or group 5 or any of those, and they have a specific behavior health need, then our behavior health case manager will join that team and we will outreach to the families and see what we can do collaboratively. All right, ABA, again, thank you for the other MCOs presenting information about ABA. It is one of probably our most frequently requested support and covered benefit. Just pointing out, like the other ones, ABA is not age specific. It can be very young children, adolescent, and into adult. And we do work with registered behavior technicians, and that is covered for a lot of the in-home services as well. All right, moving forward. All right, our specialized CTT for members that are in IDD, this is coming. And Aaron, again, if you want to jump in on this one, because Aaron's my expert on these. But this is a program specific for our IDD members. It is a multidisciplinary team approach. It is through most of our community mental health centers that offer this. And it is designed specific to staff trained on members with autism or intellectual delay who need that extra support. All right,
The only other thing that I would add to that is that the other two MCOs starting 1/1/2026, we have worked together with the providers for this service, and it is not currently implemented and will be implemented 1/1/2026.
Okay, thank you. All right, this is our PICS program, which most of our adolescents have access to their cell phones or smartphones, and they would probably more likely text and interact with us through an app than they ever will pick up the phone with a case manager. So we have this program available. It's PYX, or we refer to it as PICS. And PICS is a digital app that allows the member to speak with a person, a therapist, someone that they can talk to about what's going on in their life, get some general guidance about maybe a diagnosis, some activities for calming, coping mechanisms. So it's just a digital app. It's available for our members, and it gives them access to someone that they can talk to, or if they don't want to talk to anyone, then they can kind of go through the app on their own and have access to a lot of health education appropriate for their age.
And there's a question in the chat that I'm
Sure.
not sure, it may have been related to the last slide. So I don't know, Dan Reese asked this question, does TennCare cover the cost of the service? I don't know if that's about the CTT or about this QIX. Maybe you could answer it for both.
These are all going, the PIC system, but the last slide, the CTT, those are going to be covered benefits through TennCare. Yes. All right. And with BlueCare, we contract with Kramer Davis. Kramer Davis is specifically in the Hermitage, Tennessee area. They are a full service clinic specifically for members with intellectual developmental delay, particularly if there's genetic syndromes or some complexity with mental health, medical needs, and behavioral needs. So you'll see they have a wealth of services. They have primary care consultation, dentistry, nutrition, physical occupational therapy, and they have an ABA consultant. So the ABA consultant with Kramer Davis, they will not provide direct treatment in the community like a typical ABA service, but they are there to support the person who may have some behaviors around medical appointments. If a person does not do well in typical medical appointments and needs extra support, that's what the ABA is there to do. I do want to point out that this, with Kramer Davis, they will see ages 13 and up. They will not see anyone who's below age 12 or below, because I feel very strongly that that person should stay with their pediatrician. But with a member with IDD specifically, if they want to consult with the member's current pediatrician or offer another additional services, Kramer Davis is there. The Kramer Davis will support members in other parts of the state, but they do ask that at least annually the person is able to travel to their clinic in the Hermitage area. And then attached is a link to a referral if anyone can make a referral to Kramer Davis. But again, I just want to point out that's ages 13 and up.
And sorry, I think I missed slide back. There's another question in the chat about how does a member access the PYX resource?
Oh, do we not put a link in there? I thought we had put a link in there. Well, I will have to add that after. Great question. Thank you for catching that. We will make sure a link is added before the end of this full presentation. All right, TennStart, we didn't realize TennStart was going to be here and present, so we'll skip over this, but TennStart we have found is an integral program with our members and across the MCOs. We're very glad to have him there doing their own presentation. And then finally, youth villages are specialized CCFT. So this is a combination. We've worked with youth villages to develop this program that looks a little bit like their Intercept program, but as well as enhanced supports for our specialized populations. So particularly for children, youth from birth up to age 18, it looks just like regular CCFT, but these are the staff coming into, the therapist coming into the home has had some RBT training, so registered behavior technician. They've gone through that training. They have access to a behavior analyst who can either come on site or who is available for consultation. It is in home, and that therapist will continue to see the member in the community, and at times they can go to the school to offer some additional supports, maybe to a teacher or the school staff. Therapy is not provided in the school continually, but they are available to consult with the school if there's behaviors that cross over from the home to school and community settings. So there's also access to occupational and physical therapy, as well as some speech therapy as needed. And these are typically 3 to 5 sessions weekly, so it is a little more intensive than typical CCFT. But again, it is with a therapist who has been trained as a registered behavior technician and who has the resources and access to a behavior analyst. And again, they're not providing direct ABA therapy. That's not the intent of what the specialized CCFT is, but it is more focused for the IDD population. And with the specialized CCFT, it is statewide. It was initially piloted in the Knoxville and Knox County areas, and it is now gone statewide. So we do have access to that. If you do have a member you think would benefit from the specialized CCFT program, then you can outreach to the BlueCare case manager, and we will help make a referral to this program. All right. And then finally, intermediate care facilities, ICF, IIDs. These are programs of last resort. This is considered institutional care. It is really for members with a full-scale IQ below 70 and with significant complex medical and behavioral health needs that truly cannot be met in the community. Our goal at BlueCare is to divert a member from an ICF, but there are times where it just ends up being a necessary program. But ICFs offer ancillary therapies, your OT, PT, speech, sometimes rec therapy. They are available across the state, but there only are a few that are available to accept minors. So there's a facility there's one provider in Nashville, and there's another provider in both Chattanooga and Knoxville areas that will accept children. Adolescents, there are some that will take adolescents, but our goal is, if at all possible, to direct to other services, or once the youth turns 18, to look at home and community-based care. All right, and then the rest is just general resources available through BlueCare, community connections available if you have families that could be struggling with other healthcare, if they need help with housing, utility. We do have social workers on our team that can assist with families, but we do have some of these other services available. And then finally, if you have a family that is maybe struggling, or an individual struggling with their internet or phone help, that's just an additional resource that we put together here. And then our Care TN app. So again, BlueCare has a lot of the same services as the other MCOs. Sorry, our slides are longer. We just would like to get a little detailed in our service, but we're here to answer any questions, and our case managers are available. Thank you.
Thank you. All right. Next up, talk about Katie Beckett program.
Hey, good afternoon, everybody. Thanks for joining today. My name is Timothy Hickman. I'm the Deputy Director of Intake and Case Management for DDA. That's a mouthful. What it really means is I work across lines with MCOs, with providers, with TennCare to try to support kids and adults with ID and DD in the system. Have had the opportunity to work with Dr. Emerson, Dr. Settle, and Melinda Benzer on multiple cases, so really appreciate their discussion today. Those folks are excellent, and couldn't ask for any better partners out there. Next slide, please. All right, so just real quickly, I'm going to go through this very quickly, and obviously you'll have the slides to be able to refer back to, but did want to really talk about this program, which is a little bit different than the programs being talked about. Katie Beckett is really a program for children who don't have Medicaid. It's from children from 0 to 18 who don't have Medicaid or who are losing Medicaid, which is different than the programs we just talked about, which are all Medicaid funded. Next slide, please. Okay, so let's talk about the history of things. I like to always go back and kind of know where we've been so we can know where we're going, kind of thing. Katie Beckett, this program is named after Mary Catherine Beckett. Her name was Katie. You may be familiar with her, you may not be. But basically, she was a young lady who contracted an illness and basically was forced to be in an institution. She was forced to be in an institution because there was no law or no movement at that time to put people in the community and have them live very integrated lives. So long story short, there was a lawsuit. The lawsuit was won. It really was the beginning of community-based services. Whereas most services used to be provided in an ICF or an institution years ago, this was the beginning of the home and community-based movement. And so when you hear the term Medicaid waiver, you should be thinking that the waiver actually means that you're waiving the federal Medicaid rules for institutional care and moving those to the community. All the money and all the rules move from the institution to the community. And so just remember that when you hear the term Medicaid waiver. Next slide, please. Okay, so basically what is Katie Beckett for? It's really to provide a pathway for Medicaid eligibility for children with disabilities or complex medical needs who are not currently eligible because of their parents' income or assets. And so if you know anything about Medicaid rules, most of the time your income would prevent your child from becoming Medicaid eligible. We have lots of families out there with kids with disabilities who don't qualify for Medicaid. So one part of this program is to provide a pathway so they can eventually get Medicaid. It's also to support children with disabilities and complex medical needs, and basically help a child transition into adult life, whether that's employment, whether that's community, whatever it may be. It's also to support and empower families, basically to make sure that people get the services they need. Next slide, please. Again, the program is for children under the age of 18. Basically, you have ID or DD on one side, or you have complex medical needs. And so there's two different things. Obviously, they overlap at times, but a child is either enrolled under the ID-DD segment or they're enrolled under at-risk medical. At-risk medical essentially means that children have a nursing need or some other very significant complex medical challenge that requires basically institutional level of care or at risk for institutional level of care. IDDD is you have an intellectual or developmental disability, and you qualify for the program that way. I will say one thing about this program is I've been in state government for too long to tell you, but I can tell you this program came about in record time. This program came about through a collaboration across political parties, across grassroots efforts. I mean, the advocacy movement for this program alone was something I had never seen, and it came together in a very, very quick manner to get the program going. We actually launched this program during the middle of COVID, and so that should tell you something about the attention that this program has gotten across the state. Next slide, please. Okay, so there's two parts to the Katie Beckett program. Basically, part A is get you full boat Medicaid, get you all the things that the MCOs talked about earlier, and it gets you $15,000 in wraparound and home and community-based services on top of the Medicaid. So that's the home and community-based benefit for kids who are enrolled in Part A. It's administered by BlueCare, and each child has a nurse case manager if they enroll in Part A. Next slide, please. Here's a listing of some of the services. These are going to look very familiar to you because they're some of the same services that you see in ECF. And so kids in Part A basically have a benefit equivalent to ECF Group 4. They have full boat Medicaid and they have up to $15,000 in wraparound HCBS benefits. Next slide, please. Part B, which is the most utilized part of the program, is a very innovative new approach. In fact, it's a Medicaid diversion program. People or children in Part B do not have Medicaid. Instead, they have a capped benefit limit of up to $10,000 per year per child. DDA operates Part B. We make all programmatic decisions for enrollments based on the child's eligibility. And then we provide the ongoing case management once the child's in Part B, or we contract it out to case management agencies to do the same. Okay, these are some of the services in Part B. And remember, it's a $10,000 capped benefit, very flexible. We intended to make this as flexible as possible. And so essentially the two biggest services utilized in Part B is health insurance premium assistance, which is money provided to families to help them offset the cost of their private insurance. The most popular service in Part B is something called a health reimbursement account. And that account is basically just like you have at your employee. It's a flexible spending benefit that the state funds up to $10,000. And so this HRA can provide a lot of the things that we talked about, or I heard talk about being talked about earlier today, like BA services, respite services, therapies, clinical services, even private school specialty school tuition can be utilized through this HRA benefit. We have about 4,700 children enrolled in Part B of the program right now, and 99.9% of everybody in the program uses some or all of their funding in this HRA account. It's a very flexible benefit that families have really loved and has made a huge impact on Tennessee families. Some of the other listing of services, you can see those: vehicle mods, minor home modifications, assistive tech, non-traditional therapy reimbursement services. That could be something like equine therapy, where it's not traditional, not paid for by insurance, but under this benefit, we could pay for that. And then you have the traditional agency, home, and community-based service list of respite, transportation, supportive home care, things like that. Many of the things that you see in this list, you can get under the HRA. So again, most people use the HRA benefit in Part B. Next slide, please. Again, who's eligible? The child must be under the age of 18. For Part A, they have to meet the institutional level of care. For Part B, they must meet at-risk level of care, which means they're at risk for being placed in an institution, but they don't have to meet that level of care. Next slide, please. Okay, this explains the differences between the level of care. I'm not really going to get into this, but just know there's two levels for people to qualify in Part B, and I think I named those already. Basically, you have ID or DD, and you need care beyond which is routinely provided to children of the same age, or you have a medical diagnosis which is expected to last 12 months, and you need skilled nursing or intensive therapy services. Next slide, please. Okay, not everybody who applies will qualify for the program. We make the determination. It's not an easy thing to say no to kids who we know their families, they need services, but everybody doesn't qualify for every program, and I think we all know that. So you got to be under 18 years of age. Wait a minute. Okay. Yeah, they're already 18. They're not a resident of Tennessee. They already have TennCare or Medicaid. They have a mental health diagnosis, but not IDDD. It's very important in this program that you at least have a dual diagnosis between IDDD and mental health. It's okay to have a mental health diagnosis. A lot of the children do, but you have to have the IDDD or be at risk medical in order to enroll in this program. If you live in an institution right now and you plan to remain there, obviously you can't be in a home and community-based program like Katie Beckett. Or we don't have documentation that supports the level of care criteria, which is basically we don't have documentation to support that you have ID or DD or a complex medical condition. Next slide, please. Basically, you apply for Katie Beckett through the TennCare portal as if a person was applying for Medicaid, because what you're doing when you apply for Katie Beckett is you're applying for Medicaid, and somewhere in the application, you're going to be asked whether or not you want to apply for Katie Beckett as well. There's the information on the slide about how to do that in case you're needing to talk to a family or refer someone to the program. We also maintain toll-free numbers in each region that can help someone apply if they need assistance. So basically, DDA conducts all the intake for all the referrals we receive in the TennCare system. We conduct a face-to-face assessment in the home. We review the documentation. And we make a determination about the eligibility for the child. Next slide, please. So I think this is just reiterating what I've already said. The cap's 10,000. It's for kids under the age of 18 who don't have Medicaid or who are losing Medicaid. And so I think about DCS case managers here. I think about kids who are at risk for being in custody or coming out of custody and are reunited with families, and they may not continue to have the Medicaid benefit. This would be a program for them to apply for to kind of keep them at home and keep them integrated with their family and in the community. All right, and this is a link to additional information about the program. There's a lot more information out there than what I presented today, but I'm hopeful that this was helpful to you as you help plan with families. Thank you.
Thank you so much. All right. Carrie Ganaraja.
Okay, thank you. I am really excited to share it with everyone. And as I have listened to everyone else's and looked at my PowerPoints, I know I have too many slides. So I'm going to try not to stay on any of them too long. But if you'll go to the next one, these first 3 slides are basically a capture of our one pager. And so it's something that if I didn't send it with my slides, I can send it and it can be disseminated. And it basically tells you about our services and how to make a referral. And so you'll see that our service, we are a crisis prevention and intervention program. And so we provide, we work with a person and their system, which when I say system, I mean all the people that surround a person with intellectual and developmental disabilities who is having, mental health crisis or other kinds of crisis or instability. So their system is all the people that work with them, and we work to get them all to the table to talk about what's working, what's not working, and to create a crisis plan and do some planning and prevention. We would much rather do all our work on the prevention side, but we also have a 24/7 crisis response line, and so that's the intervention. So if the person's having a crisis or needs assistance or is escalating, we can be called and someone will provide support, work through the crisis plan, and go out and be in person if that's the appropriate response to what's going on. So a lot of what we do is assessment, analysis. We're gathering information and working with the team. So if you go to the next slide, that's the map. We are a statewide program. We are broken into 7 regions, and you can see them each there. And so a team of 5 to 7 coordinators work in that region to support the people in that region, and then they rotate the on-call, and then there's a manager in each region, and we have 3 on our clinical team to provide support. Okay, so if you go to the next slide, we talk about making a referral. So there's a slide about phases. I'm not going to get into it deeply because it's just too much information, but we are currently taking referrals for people who have a diagnosis of intellectual and developmental disorder or disability, and who are eligible for one of our waivers in Tennessee. So you don't have to have it. You don't have to be on the waiting list. You just have to be eligible. And so that covers most people who have a confirmed diagnosis of intellectual or developmental disability. And most kids fall into either having TennCare or having Katie Beckett or being eligible for Katie Beckett. And most adults are eligible with that diagnosis are eligible for one of the waivers. So it's pretty broad. And then there has to be a risk of crisis. But again, that's also fairly broad. There might be a mental health concern, some other physical or emotional or mental need that's creating instability for placement. We do not do placement, but we work with systems for people who are needing to kind of consider what placement will look like. And so you can see all the other information here. Anyone can make a referral. And so what will happen is if you make a referral, we will reach out to the referring person. And then we'd also reach out to a conservator, a parent, or the person, depending on if they're legally competent or not. So that's what happens when we make a referral. So let's keep going through the slides and we'll skip the phases. That is on the website if you are really eager to find out about our phases. So this is the 2024 data, and I'd like to share this because it really shows some concrete evidence of the effectiveness of our program. We take information on a person's engagement with emergency services before enrollment in 10 Start. And you can see, 47% of people who come to us have been to the emergency room in the past year. 37% have police encounters and 36% have been in a psychiatric hospitalization. And then you can see the graph shows those numbers going down. So we're very excited about that when we're working with a person, those emergency crisis service interactions go down. And then 85% of the time, we're able to maintain community setting when we're involved with the system. And that's really our target number, because sometimes a person does need to go to the hospital. Sometimes they really need stabilization in a hospital setting. So we're okay with that. What we really want to avoid is incarceration and some of the other negative outcomes that happen when there's instability and emergency service utilization. So, all right, let's keep going forward. Actually, let's skip this slide. You'll get all the slides. You can contact me with any questions about any of the different slides. But this bridge, I think it's a great image to sort of show the arc of our services. So when we get a referral, we determine eligibility. And as soon as we have the ability to enroll, we enroll, because we know this is crisis. And we've really been working to reduce wait times. That's been a goal of ours, and I think we're kind of getting closer to really having a less of a wait time. So then we start our assessment. We begin the intake. We want to find out all about the person. We want to collaborate and create this crisis plan that we can then work with the system to put in place. We want to work ourselves right out of a job. We do not want to take anyone's place in the system. We just want to get the system to the table. Let's start talking. Let's figure out what our barriers have been, what's working, what's not working, and move forward. So that's what we're doing as we learn. We develop the crisis plan, we train. We have a quarterly start plan, we call it, very cleverly named. That's sort of our quarterly assessment of how we're going, what's the intensity level of crisis. Ideally, we see that intensity level reducing, and that's how we know it's time to start deactivation planning. And then we work to deactivate. And when we leave a system, we always talk about who's left here at the table and what's the role of the people still here at the table. How are you guys going to do the thing that we were doing or helping to do? Who's going to do that when we're gone? Through that whole time, we're also focused on a thing we call PERMA. And PERMA is an acronym that stands for positive emotion, engagement, relationships, meaning, and accomplishment. And there's actually a little plus at the end that doesn't get shown here, but that's for all like other wellness aspects, like diet, sleep, exercise, just anything that helps you feel well. Am I coming through okay? Because I just got the unstable connection message.
Yeah, you're
okay. So good. All right. Just if I'm a robot, just cut me off. Okay, so we are working with systems to really educate on why it's so important to help people have a better life and to make choices and to get to do the things that they want to do. So that's also a big part of our services. Okay, if you keep moving us forward on the slides. Okay, so I'll stop here to say the other thing that we do is community support and education. So we really want to build capacity in the whole community. So not only are we working with people, but we are creating training opportunities. We're building a network. We're building partnerships. We are just really trying to build what we do here. If you want to look up our website, it's the easiest way for me is TN Start DDA. Search that in Google, it will take you to our website. There's a QR code here that you can use. And okay, let's go forward. We can keep going forward. I think that was kind of a restatement. We do use a biopsychosocial model, which means that we're not just looking at like, what's the behavior? What's a crisis? What's happening in this moment? But we're looking at, let's talk about all the medical things, all the biological things that could be playing into this. What are some social things? Have we lost relationships, or how are we working, and that kind of stuff? And then psychological, what are the mental health challenges, and trauma you can see in there, drug effects. There's all these kind of overlapping areas, and as we look at all of those things, we create goals about like what to do and what to do next, and what are our steps to really get to that wellness in the middle. Next slide. Okay, this is just a screen cap of our website. So you know what to expect when you go there. You see that big red button. If you want to make a referral, just press the button. It'll take you right to our referral form. And we do CET partner events. And if you want to catch that QR code, you can sign up to be informed when it's going to be in your region. We rotate through all 7 regions. So about twice a year, we're in each area of the state. Okay, I think you can keep going. I think I talked about those things. And like I said, we are due network building, but we can keep going forward. All right, I'll give you our quick current stats. We have 114 people currently we've enrolled in 2025 and 283 that we currently serve. We have served 540 people over the 4 years that we've been in place. You can see I am proud of our team. I'm proud of our numbers, so I had to share them. And then we talked about the diversion rate there. And 84% of the time when we get a call, we come in person. If it's a stage 2 or 3 call where we need intervention. We have had to be, just due to staffing, some virtual. We've had to be on virtual sometimes because there's only so much that one person can do, right, in a region. But we are committed to being in person. And just some final information. I think it might be a repeat of what was on someone else's slide as well, but we always want to connect people to ECF Choices and other resources that are out there when we start working with them. And you can skip over that slide. And I think we're at the end. I think we're holding questions for later. Maybe I'll hand it back over to you, but thank you all so much for letting me talk about one of my favorite topics, 10 Start. And you can reach out to me anytime.
Awesome. Thank you so much. Yeah, very cool. We'll keep it going. Talk about DDA maps.
Hi, everyone. My name is Bree Dormeyer. My title with DDA and the MAPS program is Transition Guide for Middle Tennessee. So I oversee all things MAPS for all of Middle Tennessee, but I also have a counterpart in the East region and a counterpart in the West region. So we are a newer program to DDA that is statewide. So you can go on to the next slide. Thank you. So just some overview. We started in 2022 where the Tennessee General Assembly awarded DDA $25 million to implement the MAPS program through DDA's Division of Innovation. So our goal through MAPS is to decrease the need for long-term supports and services by helping participants develop lifelong independent living skills at home, at work, and in their communities. So MAPS is a time-sensitive program. We offer 3 years of services and supports to people with intellectual and developmental disabilities. And even though the acronym MAPS stands for Medicaid Alternative Pathways to Independence, not to be confused, unlike ECF Choices or some of the other programs, you do not have to have Medicaid to be eligible for MAPS services. Next slide. So the Division of Innovation operates under these pillars of transformation where, oh, I'm sorry, can you go back one more? Thank you. And so we really focus on utilizing person-centered practices, finding people employment, and utilizing technological supports so that we can increase independence and really help that quality of life. So MAPS operates under what we call milestones, and those are just our goals that we can support in services. So our milestones are related to those areas of home, work, and the community. So if you think of the MAPS program, when you are enrolled into MAPS and using it to develop your plan, we have this menu, if you will, where we can take your personal goals and needs and then customize them to fit into these categories. So then under the home outcome area, we have 4 milestones or goals that we can support, such as personal hygiene, health management, financial management, and home safety. And those expand a little bit further to continue to help just increase that independence. And then we also have the work outcome areas where we can support employment exploration, post-secondary education, if that's a need, and then the community. So helping you get involved in your community, learning about transportation needs to help you be an independent traveler, and all things related to being successful out in your community. Next slide, thank you. So MAPS can be for everyone with intellectual or developmental disabilities. So we are exploring flexible and alternative milestones to help support all needs through the MAPS program, meeting the person supported where they are at to help them find success in independence, whatever independence looks like for them. So we do not provide traditional in-home services or respite services. And we also do not, unfortunately, have transportation assistance or reimbursements. But we are contracted with select DDA providers. And so these providers act as teachers, if you will, where they come into the home or out into the community with the persons they're supporting and utilize a curriculum style method to help apply and teach skill-based needs to increase that independence. Along with the annual budget to support the provider agency services for the skill increase, we also have an annual enabling technology budget. So each person enrolled in our program has access to $2,500 in monies to purchase enabling technology supports that will help promote their independence in our outcome areas. We also offer with enabling technology vendors. So each person enrolled into the MAPS program is issued a cell phone device operated through T-Mobile. The service plans are provided through DDA while enrolled in the program. And so the participants have a choice of an Android or an iPhone device to help teach skills for independence through this cell phone. And it comes preloaded with some apps through AbleLink that again help support the continuing of independence. We also utilize something called a virtual community resource map. And this is a customized map, unlike a Google map that we're all familiar with how to navigate and get places. This is a map that I like to refer to as a virtual filing cabinet. So it is a visual map where you can put supports and things all in one place, and then the person you're supporting can click what we call an asset, and it opens it up to give supports on who to contact, step-by-step instructions on how to get somewhere or what to do once you're in a certain place. So it really is opening the doors for more possibilities of independence without needing that one-on-one or direct support. And then our provider agencies. So I'm sorry. Yep, you're good to go to the next slide. Thank you. So our provider agencies receive, like I said, that payment. So it's a $20,000 budget annually for MAPS, and that is supported when a MAPS participant reaches a goal. So different than a lot of the other programs right now and services, we are value-based. And so our goal is to help the people we are supporting to reach independence, again, with whatever independence looks like. And so the provider agencies are paid out for their services once the goal is met. And so we have those 11 milestones to work from. And then when at the end of the 3-year program, when a participant achieves or successfully completes at least 6 out of the 11 milestones, then the MAPS participants themselves are rewarded with a $4,000 deposit into an ABLE account for whatever their next future steps are after the MAPS program. Next slide. So I saw that question pop up in the chat about ECF and MAPS. Unfortunately, to be eligible for MAPS services, you cannot be receiving any other long-term supports at this time. So you cannot be an ECF and MAPS simultaneously, but you can be on the ECF wait list. Same thing with Katie Beckett. If you're receiving Katie Beckett services, you cannot be enrolled in MAPS while in Katie Beckett, but we are working to transition those wanting to go from Katie Beckett services directly into MAPS. Other eligibility requirements for MAPS is you have to be a resident of Tennessee. With the exception, we have made exceptions for those living on Fort Campbell, since there are areas of Fort Campbell that have Kentucky addresses. We can support all of Fort Campbell. You have to have documentation of the ID or DD diagnosis. The minimum age requirement for MAPS is you have to be within the last 3 years of high school. And so this can look a little bit different depending on if you're graduating at that typical year of 18 or if you're staying in high school for that extended transition programs. So Minimum age requirement is going to be 15 or a sophomore in high school. And then if they're graduating at traditional 18 or senior year. And then if they're staying on, then we would look at starting MAP services around 18 or 19 years of age if they're staying through. We have no ceiling, so MAPS is open to everyone while we target that transition age where we can try to put supports in place as they're exiting the high school setting. We have people in our program enrolled up into their 60s. So we are finding success with the MAPS program, even with our aging population with ID and DD. And then, like I stated, you can't be receiving those long-term supports and services. Our application is available right on the MAPS website, on DDA's website under the MAPS program. It shouldn't take you too long to complete it. You complete it all digitally, and then our intake through DDA will reach out requesting documentation of that ID and DD diagnosis for further verification for eligibility. We can also coexist with some other programs and support. So you can be receiving MAP services, and you can also be receiving voc rehab services through VR. You can also be eligible for family support services. We make referrals to Tennessee Start all the time for some of our MAPS participants, so you're able to participate in that. And then any other short-term program that is not considered a long-term support system can coexist with the MAPS program. Also on our website, so we are just approaching, like I said, 3 years of service. Our first newly enrolled as of November of 2022 MAPS participants are in their year 3 or their final. And so we've started to highlight some success stories for our MAPS participants. So if you're ever interested in watching what some things certain people are working on with MAPS, the great thing with MAPS is it's very customizable. So we can take one person's needs for homework or community, and it can look very different from another person we are supporting in the MAPS world. So right now we have just over 600 participants enrolled in the MAPS program, and we have capacity to support up to 1,250. So lots of spots still in MAPS to provide supports to anyone in that transition age program and or beyond. Feel free to reach out if anyone has any further questions. I'm always happy to talk about MAPS. I know my counterparts in East and West are always happy to talk MAPS, and definitely happy to try to support who needs support through MAPS services and figure out how more we can support you all. Thank you.
Thank you so much. All right. All right. Now, Tennessee Strong Families and Homes.
Babs, do you want me to kick it off, or do you want to do it?
Yeah, you go first.
All right. So now we're nearing toward the end, so I appreciate everyone's patience and hanging in there. It's been a lot of valuable information, and kind of, I think most of you probably, hopefully by now, are aware a little bit about the TN Strong Families and Homes program. So if you don't mind, Dr. Corin, going to the next slide. So how we came a part of this was part of Governor Lee's TN Strong Families initiative. We were kind of asked to create some programs to really leverage our expertise to work with our sister agency at DCS to really provide some enhanced support services for kids in foster care or those that may be at risk of coming in. Eventually, we haven't developed that fully, but that's something that we are in the works on. So we did create kind of a dual approach to do this. We've kind of successfully launched 2 different tiers of this program to do it. And one is a direct care kind of service. So those are for tier 1. Thank you, Dr. Corin, for doing that. So this is providing direct care for children who are in states custody that were in, long-term hospitalizations, or those that had extended kind of stays that DCS, the case managers or program development or other, approaches from nursing were having very difficulties in finding a great kind of placement for these kids to really kind of transition to. So when we closed the institutions down over a decade ago, part of our approach to get out of that lawsuit and to get away from those institutional level cares and moving more towards this integrated community-based services approach is we built about 37, 38 homes across the state. And these are all 4-bedroom type of homes that are really accessible homes that have ambulance doors and other things. And we'll kind of see that in these next slides, but it does set us up and equipped us to really care for that medically complex child. So these are these ICF IID homes that Ms. Minter spoke about earlier in the presentation. That's kind of that same level of care that DDA was providing to our adults. Now we just wanted to be able to do that for DCS for those really medically acute kids. The other tier that we have kind of launched and has really been a great success, and I think a lot of the families that are in the foster care system really love and participate in is kind of our modified HRA program. So this is a $20,000 HRA benefit that's available currently for 1,000 children. We are looking to expand that thanks to our budget request that will begin July 1, and we're going to expand that. We're going to kind of launch that in segments. So we're going to kick off and open up 200 slots initially, and then we'll open up and reassess as the need arises to continue that. But it's a $20,000 benefit that's available to traditional foster families. So these are not going to be funding that's available for those contract provider agencies or more of those enhanced providers. They're not eligible to participate. It's not that they're not providing good care, but their DCS is already providing them an enhanced rate that really goes above and beyond that traditional foster care board rate. And we really want to focus this money on those traditional families that are receiving that lower level of funding from DCS, and then to be able to give them some financial assistance that can truly offset a lot of these kids in hopes that it will increase the placement stability in these foster care homes as we look for adoption or reunification back with the biological families. So tier 3 is where we're kind of moving towards. And part of this is looking at enhancing the provider network that's already in existence that DCS is utilizing at this point, as well as trying to bring in some other out-of-state providers into Tennessee. So we're trying to recruit them, maybe enhance some different services or make them look differently. It's not to create institutional level of care, but to provide some more forward-thinking kind of approaches. So we're looking at developing respite opportunities, so both in-home and at-home, or in-home and out-of-home respite opportunities. So whether that is something that is going to be a private provider will be operating, or it's something that DDA itself will be doing in a pilot kind of a program, just to show the need and the stability that could be achieved from the kids participating in that short respite stay. The other things that we've looked at is we have issued grants to a number of our nonprofits as well as our faith-based providers or communities across the state. So I think we had maybe 25 or 26, don't quote me on the number, but of faith-based organizations and nonprofits that had submit an application to receive grants, and this is going to be able to create a quasi Mother's Day Out program or a respite-based program in that local community. So we know that the local communities are better assessed to provide the supports and the assistance, and families and children want to be in their community, remain in that area, and they look for their community members to really provide that extra support if they need that. And then we know that if we can infuse a little dollars to either provide the training, the necessities that can go along with that, maybe this would be a benefit that these churches or these other nonprofit organizations that wanted to participate in this could use those dollars, and then to really ramp up a great program that could provide some needed relief, whether that's a few hours each week, or if it's a few hours each day, or overnight assistance, whatever that may be. We've left that up to each individual organization to make that determination to fit the need of their community. So if you can go to the next slide, Dr. Corin. So our strong homes that I talked about, so these are short-term placements. Now, Short-term can mean a number of different things. I don't set a time frame of what that looks like. So every child that's been referred to us, and I think we've had 22 to date, it had various different degrees of medical acuity. So their stabilization and their need to be to a point where they're able to discharge safely into a forever home or reunification or whatever that may look like will really be kind of individualized based on that child's needs. So we're cognizant of that. We do want this to not be a forever placement just because it's not designed to do that. So please keep that in mind and understanding as we do that. Like I said, these are formerly state ICF homes that are there. We do have a litany of provider services that are being utilized in these homes. We do have one home per region, so we have 3 current in operation that can serve a total of 12 children. Next slide, please. So part of our staffing model. So we are trying to create this as a medical fragile type of model. So we do have a medical director that oversees all of the operations of our homes. We have registered nurses, licensed practical nurses that are 24/7 in our homes. We can have up to 2 per shift at each home if needed, just depending on the medical necessity of each child or the 4 children that are in that home. We have a respiratory therapist that are available to assist for those children that are on ventilators or have tracheostomies or that have other high acuity respiratory type of need. We have occupational therapy. We have speech and language pathology. We have physical therapy, nutrition, dietitians that come in and work with kids, especially those that may have type 1 diabetics, and then really working on the sliding scale or teaching them, the values of nutrition and how we can really get our sugar levels down and our glucose down and those kind of things. I do have a BA assigned in every home. So while this is not targeted for those with severe behaviors, we do have a few that, based on their just kind of clinical presentation, they do have some outbursts, and that can be shown in physical aggression, verbal aggression, or in self-harm. So we do have a behavior analyst assigned to each of the homes that will train the staff that are working in that home as well as working with the child and in the child's team, and how we're able to kind of stabilize and to work and to develop those plans. We also have a ID home manager that oversees the daily operations of each home. We have at least 11 to 12 direct support staff that are in the home weekly. So 24/7 around the clock care. We do have those supports. We have a rec therapy staff as warranted. So as we're moving to the summertime, we'll have our rec therapists go out and really start developing community placement options or community plans to really engage and to do some other outside activities with the kids. We have a seating position clinic in each of our grand regions. So we have 3. And those sitting position clinics are really unique. So they can modify and custom mold or fit wheelchairs, or if the child is based on the child's, for example, for those with cerebral palsy. So, oftentimes the way their positioning needs are, if they're laying a certain way, it puts a lot of pressure on some of the organs, which could impact their breathing or their digestion, and it causes more harm. So they can create wedges or other types of positioning needs that will safely allow the child to be able to position and rest comfortably. We also do the same thing for in feeding. So we have those fatal 4 where kids will choke depending on the severity and the problems that they may have medically. So we want to position and make sure that the profile of the child is in the correct position at all times. So we'll create seating that can really truly benefit for that. And then we do have contract with licensed professional counselors especially for trauma therapy. I don't think it's a secret that a lot of the kids coming in have that need. So we want to make sure that all aspects of the biopsychosocial kind of model is achieved in our home operations. So if we can go to the next slide. So eligibility. So all the referrals that will come into the Tier 1 homes or our T and Strong homes, all are starting point is your regional nurse. So the regional nurse will identify the child on their caseload in their area. They will send that to Patty Slade or Patricia Slade with the director of nursing for DCS, who then sends myself and our medical director a referral, and then we kind of start working our process there to identify whether or not we think this would be a good fit or this is, the best approach. So that's kind of typically how that goes. But a child does need to have an intellectual developmental disability or something that's of such unique specialized care medically that would qualify the child after the fact. So there are things that we can look at doing it. They don't have to have it at the beginning, but we just need to have that medical acuity to be able to justify some of the other services. I think that's all I have on that. So the day in the life. Babs, you want to go through this part?
I can. We just wanted to give everyone an idea of what it looks like for our kids who are in the home. Obviously, there's 24/7 care. One of the most important things that we wanted to focus on with this slide is that we are prudent parenting. We are the de facto parent. We are treating these kids in a home-like setting in the most home-like way that we can to build normalcy for them so that they can move from our home into a traditional foster home or reunification situation. So we're building skills, promoting physical health, taking the kids to school if possible, public school, in person as much as possible. We do really force this issue a lot because families aren't thrilled, or not families, schools are not necessarily thrilled with the idea of having these higher acuity, higher needs kids in a public school setting and prefer homebound. But we really want these kids to have the most normal life we can create and make for them. So I just want to give you guys an idea of what it actually looks like for these kids in the home. And then I think we have photos coming up. And yes, I don't know if it'll do the tour if you click that. Oh, it looks like it's going to. Thanks, Caleb.
So this is a very sterile portion of the video. So this is prior to any child moving in. So this is just what our home looked like prior to the kids entering the home. So as you can see, they're all fully furnished. We do have the ambulance doors. The countertop heights are wheelchair accessible. We do have separate nursing offices where medications are locked up. We do have a lot to teach kids how to cook. The bathrooms here are accessible bathrooms, shower, roll-in showers. We do have safety beds, hospital beds, whatever is needed for the child to be safe and comfortable. Kind of a little dining area and outside the ambulance door, but then in the living room that everyone can socialize, watch TV, do different things in. I don't know why we showed the picture of the ambulance doors opening, but we did. So you just have to go with it. They were proud of that, I guess, that we had the little push button. So please just go with that. But some of this, I know it didn't show in this, and maybe it's on the other side. Okay, there it is. So the room on the left, this was after one of our first children moved into our middle home. She was allowed to decorate her room any way she wanted. She wanted purple curtains or the sheer, I don't know the right term. Please don't shoot me because I'm not an interior decorator. I'm horrible when it comes to that. So whatever that covering is, it's purple. That's what the color she liked. She loved it. The mat is based on her genetic condition. She, tends to do better on a non-hard surface, with these floors being hardwood floors. We did want to provide her with that. She has a lot of stuffies. So the interesting thing is this child, I think, was spent over a year, almost 2 years in the hospital prior to her coming to our home. So the nurses at the hospital would often give her a stuffed animal in order to get her to cooperate or to do her medical treatment. So when she arrived, they had an entire box truck that brought in the number of stuffed animals that it took. So if that showed anything, she developed a whole lot of bad habits, as far as, well, I will comply if you give me X. So we've spent a lot of time with our BA and working to kind of reshape that behavior and to really do things. And she's really flourished and done a fantastic job. Just graduated from elementary. She participated in a class activity. It's absolutely wonderful how far she's come along. On the right is we do have an Arjo lift. So children that are bedbound or don't have the ability to move easily or need, a hospital bed to go anywhere. We do have a lift that can pick the child up and can move the child safely into the bathroom that's adjacent, that's right next door to the room. And we have RJO tubs. So we can shower, we can bathe, we can do all the things that we need to do for the child without even having to physically pick up the child or to harm the child in any way. So that's just something unique that a lot of the other providers or agencies are not able to provide. So next slide, please. Okay, so we've served a total of 22 since the opening in spring of 2023. I think Babs has gone over this. We really believe in education. Every child that's been in there has received either been enrolled in school or is participating in TEIS or an early intervention service program. We have had, let's see, 3 children graduate this semester from high school. So it was absolutely wonderful. We had a few that participated in prom. We bought them prom dresses. We had corsages. We had flowers. We did photo shoots. We took them to the event, chaperoned, all these things. I mean, it's absolutely wonderful. Our staff fell in love with all of these kids that come into it, and they really do treat them like their own children. It's absolutely remarkable. I can't give our staff enough credit for that. Let's see. 11 children have discharged from our strong home and either into a foster home or being reunited back with their biological families. And that's something that we're, obviously trying to achieve. We want to be that short-term kind of placement opportunity. I think that's all we have on that. Next slide, if you don't mind. Now we go into tier 2.
Yeah.
Basil, look at this.
I'll take this one. So care coordination is the Tennessee Strong Families HRA program. And everything I'm about to tell you is going to sound really familiar to Katie Beckett Part B. So when Bo was talking about Katie Beckett Part B, the HRA program, we modeled the Tennessee Strong Families Care Coordination program identical to that at launch. We have made modifications to the program as a result of things that we have learned along the way and how this program needed to be modified to be used more appropriately in a foster care setting. But largely everything we're going to talk about right now is similar to what Bo was talking about with Katie Beckett Part B. So it was intended to support foster families and offset the financial burdens associated with the high medical and high behavioral needs, to stabilize placements for kids who come into foster care. And part of the reason for that is at the time that we started this program, the stability rate for kids in foster care was sitting at, I think I pulled it up just a minute ago and typed. Less than 68% of kids have maintained a placement with 2 or less moves. So we wanted to prevent these moves from occurring for kids with disabilities because of the increased trauma and ACEs that were occurring for kids who have IDD. So we used a healthcare reimbursement account model that is a $20,000 account that foster parents have access to either a card or to submit claims to be reimbursed for expenses that they incur above and beyond a typical foster care experience. The way that we implement this program is with independent support coordinators who are assigned. Those are what we call our version of a case manager that works with the family to facilitate this program. So eligibility for Tennessee Strong Families, all referrals come from the DCS case manager. So the hope is that the DCS case manager would identify children on their caseload who either have an intellectual or developmental disability or are enrolled in TEIS. They would make the referral to DDA and provide the documentation that supports that referral and that diagnostic information or delays that are occurring so that we can enroll the children into our program. So some of the most common diagnoses that we see are autism, Down syndrome, CP, fetal alcohol syndrome, those type of things. When children come into custody and you see those diagnoses on the paperwork, that's an immediate trigger for you to go ahead and make that referral so they can be enrolled in our program. The children must be in a traditional foster home. Trey talked about this at the beginning. And what that means is the foster home cannot be in a unique care agreement with DCS. If you aren't sure, go ahead and make the referral. We will follow up on it. We will check into that to be sure whether or not the placement is appropriate for this program. So don't not make a referral because you think that they may not be eligible. We'll make that determination. Any child enrolled in TEIS is eligible for this program. And then if you're a DCS case manager and you don't have the link, can't find the link, lost the link, you can email that long email address right there, and I'll send it to you so you'll have it. So what kind of therapies or items are covered? This is the biggest question that we get asked. And what we're trying to do with this program is offset costs and then encourage families to seek out therapies or interventions, especially non-traditional therapies, that they otherwise would not have gotten for this foster child because the funding was not available. So any therapy item or activity that the child's medical team, and that can include their pediatrician, their BCBA, their speech language pathologist, whoever the licensed professional that's working with this child is saying, hey, it would be great if this child had this. That's something that we would want to be using these funds for. So anything that the team has decided is medically necessary, these funds would be appropriate for. Go back to that slide for one more second. The second part, decisions about individual child's unique needs will occur between the team. And so where this comes in is I'll get emails a lot from either foster families or DCS case managers that are saying, hey, will this be covered? Like today, I got an email that said, hey, will a portable ramp be covered? And the answer is, I have no idea, because the documentation has to support what we're asking for. All of the paperwork has to be done. It has to be signed by the clinician. The child's disability has to match the thing that they're asking for. So the answer is going to be very, very specific to each child's unique needs. So there's no blanket, like this specifically will always be covered. It's really going to depend on the unique situation of each and every child. All right, now next slide. So one of the most common uses we see for the funds is respite care, and that's self-directed respite care. It's not the DCS definition of respite care. So it's families are free to seek out respite care of their own choosing at a rate of their own choosing. And then they submit documentation of claims that includes who provided the respite, how many hours, what rate, and they upload all that into the system and then are reimbursed for that respite care. We also do mileage reimbursement. I would not recommend that. The TennCare rate is almost 3 times our respite or our mileage reimbursement rate. So I wouldn't use that, but it does exist. But for our foster families, it doesn't make sense. And then sensory regulation items, educational toys, developmental toys, communication devices, like a Dynavox or an iPad with specific app technology. Those types of things would be covered. And then feeding therapy items above and beyond traditional feeding therapy. And then to the right-hand side, you'll see some hyperlinks. Allie, who's on this call, and she's on our team, created some one-pagers of families to get them, or of items where families could start thinking about, I've never had a kid with fine motor delays who's 3 years old. I don't know what to think about or what to ask for. So she gave some really good examples of how families could get started if they have no idea because they've never encountered this specific delay before. All right, next slide. So care coordination within this program. The way that we deliver this service model is through independent support coordinators, or ISCs, who provide care coordination specific to the program. Our ISCs have been doing this work specific to care coordination of individuals with developmental disabilities in our adult services for years. They're very familiar in this space. They're comfortable in it. They have a really good grasp of what the adult resources are within the community. And we've now asked them over the past 2 years to expand into the child population. So they are, and when they did that, about a year after we moved them into this space for kids in foster care, Katie Beckett also began using our ISC service delivery model to provide this same structure for kids who are in Katie Beckett waiver. So our ISCs are now pretty well versed in what resources exist for children, but we're continuing to develop that out. And then, yep, we can keep going. Next slide. So the ISC responsibilities for this program is they go out and meet with the family, usually face-to-face, sometimes virtually, sit down with them, talk to them about the care and the needs of the child enrolled in the program, the needs of the whole family, how this program and how these funds can support the family to create a person-centered support plan for the child. And they educate them about how the HRA program works, all the rules and guidelines that they have to follow to get reimbursed for things. And then they check in with the family once a month to see how things are going, see what the needs are, if things have changed. And then they meet with them every 6 months face to face, either virtually or in person at the discretion of the foster family. And then they touch base with the DCS case manager quarterly just to make sure that the goals align, the plan's still the same. Are we headed for a trial home visit? Are we headed towards an adoption? Just to check in to see what we need to do on the account side related to the permanency of the child over time. And then identifying any additional supports and services that the child may need and making those recommendations to the foster parent. So the DCS caseworker responsibilities. We want DCS caseworkers to be identifying kids who may be eligible for the program, submitting those referrals into our system, and then providing us with the documentation that supports that diagnosis or supports the delay or something that lets us know why this child would be eligible for this program. We want them to touch base with us at least quarterly to make sure that we understand what's going on with the permanency of this case. And then let us know if there's a disruption in the foster placement or when the reunification happens. And the reason for that is because the HRA account is in the foster parent's name. So if the child moves from one home to the next home, we can't just pass the card along to the next foster family. We actually have to terminate it and then take the balance on the account and put it in a new account for the new foster family to have access to the resources, and then train the new foster family how to use the funding, how it could be most appropriately made available to the new foster family to stabilize the placement there. So in the case of a disruption or a transition of some kind for a child who's in DCS custody, as I mentioned, the HRA benefit follows the child. So if the foster family originally started in January with $20,000 and foster family A used $9,000 of that for whatever the needs were, then if the child were to transition to a new foster placement, the $11,000 account balance would move to the new foster placement. And when that happens, all items or services that were purchased for the child of that $9,000 will also move with the child to their new placement. That's also true for reunification. Everything purchased for the child moves with the child. It's the property of the child. So for reunification, during the trial home visit, the foster parent has the option to leave the account open and then submit any claims that the family is incurring during that trial home visit period. It's totally up to the foster parent depending on their relationship with their reunification parent. And then in the case of adoption, the family has access to the funding for 365 days post-adoption. So they are able to continue to use the funding during that first year to go ahead to stabilize the adoption. So success stories and impact of this program. Our program has achieved a placement stability for 99% of the children enrolled in the program. So 99% of our children enrolled in this program have had one placement move or less. 1% of our children have moved over time. And I think we've served over 1,000 kids. So we're looking at about 100 kids who have moved. That's still significantly lower than what we're seeing in the traditional DCS setting. So we know we're making a huge impact. We have the data to prove it, and we're really proud of it. And we're proud of the foster parents for hanging in there and feeling supported as we're rolling out this program. We did a survey for feedback from our foster families, I think October of November of last year. And this is some of the feedback we received that just let us know how they're using the money, what they're using the money for, and the impact it has made on them. So I think that's my last slide. Oh, Trey, this is you again.
We can get through this. I've already kind of mentioned at the beginning, so I know we're out of time, so we can go ahead and skip that part.
Oh, that's all our contact information. So that's it from us. I think we were last, right?
Yep.
Correct.
Well, I want to say thank you to Caleb, thank you to Michelle, and thank you to Melissa for helping us. This took us months to plan and prepare and coordinate. And I just want to give a shout out to you guys because I thought this was awesome. We did great.
Thank you all so much for this. I mean, this is great. I think just to know what resources are out there and available, I feel like working with this population of kids, I end up so frustrated that there's not enough, or in that I don't know enough about how to help kids, direct people to access. So this is hugely helpful. So thank you all so much for all of this information. I also want to say that we've recorded this. So sorry to anybody who picked their nose on camera. We'll try to edit that out. But what we're going to do is we're going to post that online, and we'll send out a copy of that recording, so that if anybody wants to share this with other people, if people want to have access to this information later, they can. I think we can stick around. I mean, we have run over, but we might be able to stick around for a few minutes for if there are questions. But I also want to encourage anyone. I put a link to a survey in the chat. So if anybody wants credit for being here today for any reason, there's a certificate of attendance in there. So if you fill out the survey, you can save that certificate of attendance for your records, to just show that you were here and you participated and hopefully listened and learned as much as I did during this talk today. I also want to point out that Melinda put in the chat the link for how to access PYX. There was a question about that earlier, and so she was able to get that link, and it's in there as well.
Yeah, and thanks to everyone who participated. We were so excited. It's kind of like when you have a party, you're hoping someone will show up, and this was a great attendance, and people stayed longer than we expected that it was going to take to bring this information. So thanks to you all who hung in there with us.